Good evening, everyone. Thank you for joining our online CME live today from Gleneagles Hospital, Kota Kinabalu. My name is Luciana, and it is with great pleasure that I welcome everyone to our online CME live event, especially to those who have followed and support us from the beginning. Today, we have Dr. Jayendran Dharmaratnam, our resident clinical oncologist, to share with us on cancer management in the COVID-19 pandemic era. Before we start, let's get to know Dr. Jayendran a little bit more. Dr. Jayendran is a Malaysian doctor practicing as a consultant clinical oncologist. He completed his MBBS at the University of Mysore, Kasturba Medical College in India in 1979. After a period of in-service training in the Institute of Radiotherapy and Oncology in Hospital Kuala Lumpur, he subsequently went on to do his postgraduate training in United Kingdom. In 1993, he received the Diploma in Radiotherapy Oncology from the Royal College of Radiologists in London, and in 1994, the fellowship from the Faculty of Radiologists, Royal College of Surgeons of Ireland. He chose to actively pursue his interest in sport medicine and received a diploma in sport medicine from Avid Cowan University in Perth in 1998. During his 30 years as a doctor in the government service, he has served in 3 government ministries, which are Health, Education and Defense, in various capacities. Since the beginning of 2010, he has been in private practice. If you have anything to ask Dr. Jayendran, you can email your inquiry to the email address as stated below, and Dr. Jayendran will try to answer your question after this talk ends. Without further ado, I will pass this session now to Dr. Jayendran. Good evening, Dr. Jayendran.
Good evening. Thank you, Lucy. Good evening, folks. Thank you for tuning into this webinar, and thank you for giving me this opportunity to talk to you. I don't need to introduce more of myself, but let me tell you that in the better part of 25 years that I've been as an oncologist, I've seen many challenging situations, but of course none as challenging as what we are facing now. So, I'd like to take this opportunity to give you a kaleidoscopic perspective of what cancer management involves in the present situation and what it may involve in time to come. Okay. Sorry. Now, for those of you who have maybe have been exposed to some amount of oncological practice, you will understand that oncological practice is something which is quite complex and maybe to a certain extent subjective. Many of the decisions that are made as far as cancer treatment is concerned will be based, a lot of it, on evidence-based medicine from clinical research and clinical trials. It will also be based on personal experience with the treatment modalities or chemotherapy regimens. Of course, it has a lot to do with patient profile, the kind of general performance status of a patient, comorbid problems that a patient has. It depends a lot on local therapeutic habits, and to many of us, it also depends on how we perceive the data that we read, and that all goes to make towards the treatment choices that we make. In the last 100 years or so, there are many treatment modalities that have developed as far as cancer treatment is concerned, and with a view towards either preventing cancer or the best situation to cure this very difficult disease, and in the worst come situation to be able to provide a quality of life through palliative means. So it involves various modalities of treatment besides preventing cancer, primary treatments like surgery, radiotherapy, systemic treatments like chemotherapy, endocrine and biological treatments, and so on. And there are, of course, always newer treatments, novel treatments that's coming along, but when we do consider all these new treatments, one must take into consideration the benefit of the existing treatments. Cancer treatment is not all about surgery or radiotherapy and chemotherapy, but there are so many other disciplines of treatments that's involved. One would look into things like nutritional therapy, managing pain, rehabilitation, the psychosocial aspects of treatment, and these days a lot of people are into even alternative medicines, which become integrated into the whole concept of cancer care. In a developing country like ours, we must keep in perspective there are some very important aspects. We must make treatments accessible to all strata of the community. We must make sure that treatments are comprehensive, which, as I pointed out in the earlier slide, we have to make sure that treatments are cost effective. We are not a developed country like Japan or United States where we can afford to give patients the best treatment that there is. Also, in a country like Malaysia, where we have different cultures, we need to take into consideration patient-centered care and the different values and cultural needs and perspectives. For example, some patients may not be able to take medications that are porcine based or bovine based and things like that. So these are some of the perspectives that we need to take into consideration. So these are the basic principles that on which cancer management, at least in Malaysia, has developed. And how do we manage the future challenges in this present pandemic situation? Firstly, it must be stated that no healthcare system has been fully prepared for such an unparalleled health crisis, and you can see that even in the developed countries, in US and Europe and so on. The COVID pandemic has put a tremendous strain on healthcare services and has affected directly or indirectly the course of treatment of many common illnesses, including cancer. What we do know is, as in many diseases, the impact appears to be to a certain extent time dependent. As you have seen in the early stages of the pandemic, the mortality was much higher. Obviously now we seem to have gotten around knowing how to manage the pandemic, and secondly, it also is influenced by the logistics and the quality of care. For example, things like integration of transport. As you know, most of the cancer centers for treatment of cancers are mainly in the urban areas. And what happens to patients who are in the rural areas? How do they get access to the treatment facilities? There are other things like distribution of resources, the different regulations, national, at different levels. The resources like trained and efficient manpower, these are also influence the impact of this pandemic. As far as epidemiological data is concerned, we have some evidence from China to Italy and even some meta-analysis that suggests that the severity of the disease is higher in patients with cancer, especially those with hematological malignancies. Why? Because hematological malignancies seem to be associated with more of immunosuppression. Lung cancer, for obvious reason, because the COVID virus resides to a large extent in the lung tissues. Advanced disease, advanced cancer, and those who are older and with comorbidities like obesity and so on. But solid cancers per se was not actually associated with a higher viral load in most of the analysis, univariate and multivariate analysis, as compared to those patients without cancer, unless of course the situation changes because the cancer has progressed or because the patients are on treatment which reduces which just causes immunosuppression. So in general we can say that cancer patients at risk are those who have advanced disease, poor performance status, those who are smokers, those who have comorbidities that I have mentioned, certain types of cancers, those who have been on treatments like cytotoxic chemotherapy for extensive periods, extensive radiation therapy, those who have undergone stem cell transplantation after high dose chemotherapy, and those who are also on treatment, systemic treatments, which to a certain extent cause some amount of immunosuppression. Diagnosis of COVID-19 is not very dissimilar in patients with cancer or those without cancer. The usual symptoms are fever, dry cough, breathlessness, chills, muscle pain, headache, sore throat, rigors, and very characteristically loss of taste and loss of smell. The laboratory findings quite similar to those patients also with cancer. They can demonstrate leukopenia, leukocytosis, lymphopenia, elevated liver enzymes, elevated LDH, elevated inflammatory biomarkers such as C-reactive protein, ferritin, D-dimer, CPK, and also elevated serum creatinine levels. Many of these are also independent risk factors for the severity of the disease. As far as radiological investigation is concerned, quite consistent with viral pneumonia. If you do a CT scan, you will be able to demonstrate bilateral ground glass opacifications, preferentially distributed in the periphery of the lower lobes. So, diagnosis of COVID-19 may be quite similar in some ways to all the other viral infections like influenza and bacterial pneumonia. This itself is not much of a problem for oncology because we're quite used, it's part and parcel of oncological hematology and hematological practice to be dealing with serious infections concurrently with cancer. But the diagnostic conundrum comes about when you realize that this kind of presentation exists in not only patients with cancer, those who are also on cancer treatment like immunotherapies and common cancer infections and so on. So it becomes can become a diagnostic problem. There are certain kind of cancer patients who seem to be more impacted as a result of this pandemic. For example, hematological patients with leukemia, myeloma and so on, they have a high risk of mortality to an extent because they are more immunosuppressed, partly also not only the disease but also because of the treatments that they undergo. Many of them are on high dose chemotherapy followed by transplantation, allogenic or autologous, and so the immunosuppression itself causes greater morbidity. Patients with neurological cancers like brain tumors and all that, the reason for them being impacted is because many of them require post-surgical treatment, as in ICU, and ICUs generally spell higher morbidity for patients with COVID-19. Gastrointestinal cancers like stomach and colon cancers and all that, these cancers can progress rapidly, and when patients are diagnosed with such cancers and further investigations and staging and all that becomes delayed, then it leads to them getting depressed, worried, anxious because their treatments are being delayed. Sometimes their treatments are being modified. They are not having optimal treatments. Patients with lung cancer, as I mentioned, there can be a diagnostic conundrum, and also patients with lung cancer and COVID-19 have a higher risk of pneumonitis and even certain manifestations like the cytokine storm. Okay. Now, this is a picture, radiological picture of a patient with COVID-19, which could be misdiagnosed as patient with advanced cancer, or even could be pneumonitis due to chemotherapy induced, or even immunotherapy or targeted therapy induced. So it can be a problem in making a diagnosis if you see a patient with a CT scan like that. Other patients who may have problems are, for example, patients with gynecologic cancers of the cervix, which in the more advanced stages may not be amenable for surgery, and the normal treatment strategy would be chemoradiotherapy, where it requires more than one modality of treatment. And this can pose logistic problems, not to mention that when you have 2 or 3 treatments together, there's also a greater degree of immunosuppression. Elderly patients with prostate cancer. We know elderly patients are more likely to have higher mortality and morbidity from COVID-19. So how do we deal with them? Obviously, we need to reduce their hospital visitations, screening, imaging, biopsies, all these may be suspended or delayed. Patients who are on low-risk treatments may be deferred, and even those with high-risk treatments who may find that surgery may be the optimal treatment, but maybe have to have some treatment modifications whereby we can use hormone androgen deficient treatment and radiation therapy in order to delay their primary treatment. Children with cancer, we know children with cancer, children generally are relatively immune to COVID virus, but however, the psychological stress that it puts on especially their families who are waiting for their children to receive cancer treatment, that may be something to be considered. Besides these direct consequences of this pandemic, we can also talk about the less tangible consequences of the pandemic on cancer care, from screening, treatment, the psychological stress, palliative and supportive care, the multidisciplinary management, health tourism, morbidity and mortality for cancer care providers, and the impact on clinical trials, which is a very important aspect of cancer treatment also. Cancer screening, I think it's pretty obvious that national screening programs will become hindered. Even patients who have signs of fatigue, change in bowel habits, weight loss, and feel that they should go for procedures like colonoscopy and endoscopy might feel stressed out because these procedures are suspended due to the risk of aerosol contamination. Women who have generally been going for breast cancer screening, mammograms, and pap smears and things like that also may find that these screening procedures have been delayed or cancelled or whatever. And anyone who has a lump or bump and requires biopsy, surgical excisions, may have their procedures also delayed. Even radiological investigations may be delayed because of logistic reasons, and also due to the hospitals introducing, being imposed because of the lockdown and SOPs and so on. As far as treatments are concerned, treatment pathways are also modified to reduce the risk of treatments like surgery or radiotherapy to reduce the risk of infections during treatments such as that. And there are situations where a patient goes to a hospital and then comes out and says the patient caught the COVID-19 infection while in the hospital. And then the word goes around, and then after that everybody gets scared to go to hospital because they believe that they are high risk of getting COVID infection. So, and also the other logistical issues, and all from the time to time the new hospital SOPs that are being introduced, all this has an impact on the community who seek treatment, especially for diseases like chronic NCDs like cancer, high blood pressure, and so on. Then of course there's lots of treatment modifications that have been implemented. Radiotherapy treatments has to be abbreviated, chemotherapy schedules have to be switched to schedules which are probably less than optimal, and even in some cases they have to be switched to oral chemotherapy. Even novel treatments like targeted and immunotherapy, which have been shown to have a good outcome on cancer patients, but they require a certain level of logistics and implementation, and because of that they are delayed. As far as complexities of radiotherapy is concerned, I'm sure many of you realize radiotherapy is a very complex process involving multiple levels of multiple processes, from the time patient imaging to the patient being planned for treatment, the verification process, and then before finally the patient goes for treatment. In the process, there are a lot of high technical radiotherapy systems that they are exposed to. Even the staff, we have different technical support teams that are involved, from radiation physicists, radiation therapists, and so on. The other thing to take note is the fact that radiotherapy resources are only available in major hospitals. And in the whole of Malaysia, for instance, there are probably radiotherapy facilities in only about 8 or 9 urban areas. So what happens to people who are living far away in the rural areas? How do they get access to these treatments? Radiotherapy is also something, it's not a one-day affair or 2 days affair. Treatments normally take weeks to months. So in the process there may be delays in interruptions in the treatment, and that can compromise on its therapeutic efficacy. Given the long course of treatment for radiotherapy, the chances of patients who come daily for the treatment of getting infected, and also the chances of infection for the care providers, is much higher. With regards to chemotherapy, as I mentioned before, there is no one chemotherapy regimen that fits for everybody. There are various types of chemotherapy regimens that one may consider based on their practice. Unfortunately, in this pandemic, there are no international guidelines what kind of treatment, what kind of chemotherapy regimens for what kind of cancers and that sort of thing. So it's a bit of a guessing game sometimes. Those patients who are undergoing chemotherapy will need to be go through stringent screening and thorough testing, and as a result of that, chemotherapy may be delayed. It becomes an IQ affair. Isolation and quarantine will be maybe the norm. So patients may be isolated for days sometimes before they can be considered for chemotherapy. Then the other issue of logistics. Fortunately, maybe in Malaysia we don't have that much of a problem on that. But there are, if I was an oncologist somewhere in Zimbabwe or some place less developed, problem of logistics and supply of drugs, and even there are centers we know that where the daycare services for chemotherapy has been shut down because the hospitals are not able to accommodate the treatments. The other aspect is the dose reduction. If I'm an oncologist, I'm sitting and looking at the opportunity to provide an optimal dose of chemotherapy for a patient, I might decide on having a dose reduction because I may not be able to monitor my patient regularly to see if the patient will have potential side effects. So it would appear to that dose reduction may be better but not optimal strategy in some cases. Now, one of the biggest problems that we have already, in fact, there are enough data to show that many patients, especially during this pandemic period, and who have NCDs, non-communicable diseases, undergo a lot of psychological stress. Cancer patients, for example, may feel isolated and can even experience emotions of guilt, especially if they have family providers who are trying to help them while risking because of not being able to implement social distancing and so on. Quarantine is something that many of us, even people who are not sick, find it difficult to go through. It can create anxiety, irritability and depression. The social isolation and need to stay at home causes loneliness, and this can be also a high risk of mortality. We do know for a fact that stress is one of those that does impact on mortality of cancer. It can cause immune suppression and things like that. So emotional distress has negative effects on the outcome of cancer patients. The other indirect consequences of pandemic on cancer care is, like, for example, how one would implement multidisciplinary management of cancer, which is a very important aspect of cancer. Quite often in hospital settings, when a patient has been diagnosed with cancer, they get from the they get referred to an oncologist, who may then refer to a dietitian, or may refer to a gynecologist, or may refer to a physician. The patient gets shunted around, and that's where a proper implementation, multidisciplinary management helps in reducing the inconvenience to patients. That becomes a problem to implement during a pandemic like this. What about the access to a late stage of care, for example, palliative care and supportive care for patients with advanced cancers? So this can also put more stress on a home care support system. Now, talking about health tourism and clinical trials. Health tourism, well, I suppose this is something that affects more doctors. I mean, there are patients who come for health tourism to Malaysia come mainly for some of these tertiary services, of which cancer care is one. My own experience, and having worked in hospitals like Malacca and Pulau Pinang, where a lot of cancer patients come from Indonesia and other countries, because they perceive that in Malaysia we provide a better level of cancer care, and they come in droves. It's sad that many of them are now not able to get access to this cancer treatment, or many of them who have been coming cannot continue their treatment. So it puts a lot of stress on them. Not to mention, of course, the fact that the doctors also lose out on revenue, the hospitals lose out on revenue, and indirectly the country also loses out on revenue. Conducting clinical trials. Those of you who have been involved in clinical trials know what a rigorous process it is. It does benefit not only the drug companies and which are involved in clinical, but for patients who have tried all the various treatments and have failed. Clinical trials give them access to drugs, novel drugs, which have shown to improve the outcomes for many of these patients. Now, during the pandemic, even before, forget about the pandemic, we know that clinical trials involve very rigorous process of recruiting patients, monitoring patients, randomizing patients, drug administration for these patients and things like that. Very rigorous process and due diligence and all that involved. This becomes a problem during the pandemic, and as a result, many clinical trials had to be just stopped in between. Of course, we all know how much the pandemic has impacted on the frontline provider, healthcare providers, and it's the same in the case of cancer care providers. There are many who have given up their lives in the course of treating diseases, and that includes cancer too. So, in this present pandemic situation, we are looking at how we can mitigate the risk of this cancer together with this COVID pandemic. And there are some strategies, one of which is, of course, how we go about screening and testing patients. We know that clinical signs of COVID-19 are non-specific in patients with cancer where occurrence of infection is highly prevalent. Patients with fever or findings such as cough, breathlessness and all that are especially a higher priority for COVID-19 testing. So testing becomes very important aspect. But more than testing, it is important that people obviously comply with the standard operating procedures. We know we have been again and again briefed on the importance of standard procedures like face masks and hand washing and social distancing, so that cannot be overemphasized. Importance of screening and testing is that it can inform decisions about delaying cancer treatment where it's necessary and increasing the protection of healthcare providers and other patients. So SARS-CoV RNA testing is very important, especially when we are dealing with cancer treatments which can cause immunosuppression. When you talk about immunosuppressive procedures, basically we are talking about treatments such as cytotoxic chemotherapy, stem cell transplantation, immunotherapy, and even high dose corticosteroids. Now, as far as testing is concerned, it's a bit subjective. Some hospitals are testing all patients, like even in our hospital in Gleneagles, we are testing all patients admitted for inpatient care. The same cannot be said maybe for all centers in all countries, but it is, of course, is good to prioritize testing according to risk groups, and some institutions follow a very selective approach to testing based on the clinician's judgment as to the immunosuppressive potential of a specific treatment or regimen. Just take, for example, I'm an oncologist and I'm treating a patient with advanced colorectal cancer. We know that the likelihood of treating with a very intense combination of chemotherapy like 5-FU, irinotecan and oxaliplatin, which is part of the FOLFIRINOX regime, it's probably more effective, albeit with higher level of toxicity and immunosuppression. Whereas the standard regime may be only a 2-drug regimens of 5-FU and oxaliplatin. So, if in a situation where we think that the patient can be monitored well, using a very intense chemotherapy like FOLFIRINOX will be good. But in a situation like this pandemic, where we may not be able to monitor the patient frequently enough, and also where we do not want a high degree of suppression, then we will obviously use a less intensive regimen. So, treatment regimens are being influenced as a result of this pandemic. And of course, testing becomes more important where you are using this high dose, high intensive chemotherapy regimens. Some institutions routinely test all patients with hematological malignancies like leukemia and myeloma, so on, because these kind of cancers are associated with a degree of immunosuppression, or because they are already receiving certain treatments, targeted therapies like monoclonal antibodies, which itself causes certain amount of B cell depletion. There are some centers which also treat routinely lung cancer patients because they undergo surgery, bronchoscopy, or high-risk outpatient testing like pulmonary function tests. So testing may be subjective: who to test, when to test, how much testing. The gold standard for COVID-19 testing is the PCR, RT-PCR polymerase chain reaction test. However, and where the swab is got from the nasopharyngeal area. However, this is not the only test that's available. The problem with the RT-PCR test is it takes time, it's very complex, it's expensive, and so on. And because of that, there are other testing techniques which are faster, also quite efficient. Like, for example, the RTK antigen. In our hospital, we use both the RT-PCR and the RTK antigen testing. And I think in time to come, there will be many more different kinds of test strategies, technologies that will be available. Even in the best testing at the moment with the RT-PCR, there is a high level of false negatives. And we must understand that even there are patients with cancer may harbor negative viral PCR expression, but may still be infected and contagious. And because of that, there are some patients who may require a second round of PCR testing to improve the sensitivity. As testing becomes more widely available, it may be reasonable in the future to be able to test all patients, whether they are symptomatic or asymptomatic, as long as they are going to be receiving immunosuppressive anti-cancer treatment. So it's a changing paradigm of cancer care which will continue to evolve. And how do we go about managing patients who are who have cancer and have potentially COVID-19? There's a wide spectrum of patients who could present. Patients with cancers who have active COVID-19 infections, they may be symptomatic or asymptomatic carriers. There may be patients who have a history of COVID-19, they may be exposed to COVID-19 or unexposed to COVID-19. So there may be a broad spectrum of patients, and trying to manage them requires a more dynamic and tailored approach, and which requires every hospital's resources and every physician's experience in dealing with that. So there's no ideal approach. Cancer patients tested positive, there is continuously with the pandemic, there are more and more patients getting tested which are positive, and it may put a lot of strain on cancer centers. Many of them may become overwhelmed, and as a result of it, there may be new guidelines that may be issued from time to time by the local and national authorities. Oncologists must keep in mind that beyond any scientific speculations, if this COVID-19 outbreak continues to extend and the resources become limited, the problem that may arise is that providing a high level of cancer care would become more of a problem than the COVID-19 infection itself. So we should be looking at minimizing the risk and finding safer alternatives. How do we go about? Well, it's not only during the pandemic, but at all times. Before we treat cancer patients, we must have a proactive advanced cancer planning, which should be put in place. Along the way, we should look into considerations such as limiting exposure to patients and staff. Where necessary, we may have to postpone diagnostic procedures, especially if these cancers are at a low risk of rapid progression, maybe like low risk breast cancer or low risk prostate cancer. Staging procedures is generally part and parcel of whole cancer management, but it may need to be deferred in situations like the pandemic, and probably undertaken in those patients who are at most risk. One thing we must understand is never take this infection for granted. Evaluation of cancer patients for COVID-19 must be intense. Remember Murphy's law. They says, if anything can go wrong, it will go wrong. So admissions for cancer treatment will require rigorous evaluations. Patients will need to be recorded for fever and cough in case they may be having COVID-19, even if it's not detected on the testing. Routine blood tests, and even in some centers they even do CT scans of the lungs because of the suspicion of COVID-19. Watch out for low neutrophils, low lymphocytes, because these may be signs also of COVID-19. Patients with suspected pneumonia will undergo COVID-19 testing and CT imaging, and in many cases patients will be kept in isolation room and observed for a period of time before they are admitted. We in our hospital, we generally do that. We will put them in an isolation room while we do the antigen test, and maybe after about 2-3 hours, when the test is negative, then we admit them for chemotherapy and other treatments. When it comes to surgery, well, the Center for Disease Control and other organizations, World Health Organizations, have given some directions on how elective surgeries at inpatient facilities should be scheduled. Rationale for delaying elective surgery is conservation. Yes, I mean, one of the things that needs to be considered, especially where resources are low, is that when you do elective surgeries, we must take into consideration the availability of ICU beds, personal protection equipment, and so on. And one of the important things is that the priority should be on limitation of viral spread, minimizing risks to patients and care providers, especially in the post-operative period. Cancer surgeries generally should not be considered elective, because cancer is a life-threatening disease, and it should be undertaken where and when cancer surgery should be undertaken where and when necessary, based on the rapidity of the disease evolution. Like the patient has got typical signs of brain tumors, we are not going to say delay the treatment until a more suitable period, because brain tumors with increased intracranial pressure are emergencies. Somebody with spinal cord compression and so on. And there are other cancers like breast, colon, pancreas, stomach cancer, and all, where cancers may be rapidly progressing. In this kind of situation, the surgery should be conducted immediately as and when necessary. But important to understand that as far as possible, minimize the need for emergency procedures. So a surgeon needs to be very wise and make the right decisions when it comes to the timing of the surgery. You don't want to delay the surgery until it comes to a situation, it becomes an emergency. Then it becomes more complicated, and then it becomes more likely to consume the limited resources that we have. So timing is important. So other perspectives from the surgical point of view is, whenever you do treatment, which this of course applies to all situations, whether it's radiotherapy, chemo, always consider the benefit risk criteria. If there is, for example, if there is a patient who is got cancer and she has got comorbid symptoms of obesity, high blood pressure, and diabetes, and happens to have a knee problem and she wants to go for knee surgery. Now, that knee surgery, the risk from doing the surgery will be much higher than the benefit, especially at this pandemic period. So it is something that can be deferred to a later stage. So one has to always look at the benefit risk criteria. In some centers, surgeons put patients into different risk categories, high, intermediate, low, for the purpose of pre-assessment and screening. Those who are on the low risk category may not need to be intensely assessed, but those in the higher risk category, they may require repeated testing, even isolation and so on. So these are things that the surgeon needs to take into consideration. In busy centers, it is better to have a triage system and with multidisciplinary involvement in order to be able to screen the patients who require elective or emergency surgery. Selective palliative procedures. There are certain palliative procedures which may, even though it says the word palliative, but may require emergency treatment. For example, relief of pain and suffering, or even neurological deficits like spinal cord compression and so on, that may need to be immediate surgery. A lot of times need to take into consideration the availability of intensive care units if the patient is going to be likely to be spending post-operative period in an ICU. There are situations where maybe there is low risk. This can be in a situation like breast cancer, where surgery can be deferred because there is another strategy of treatment that can be considered. For example, neoadjuvant treatment, which can delay the cancer process. A patient with hormone responsive breast cancer may have neoadjuvant treatment with hormone therapy, or even in some cases chemotherapy, to delay the primary treatment, which is surgery, until a more suitable time. So neoadjuvant treatment is another strategy that a surgeon may consider if he needs to delay the surgery. As far as radiotherapy is concerned, well, radiotherapy is also a very important treatment, especially when surgery is not possible and needs to be considered with curative intent for rapidly progressive cancers. Of course, treatment with radiotherapy, which I shall emphasize later again, is now being modified. The radical treatments sometimes used to take 4 to 6 weeks for radiotherapy, but with this present situation, they are being abbreviated, and treatments are being given in a shorter period. You must understand the radiotherapy in principle has been given over a longer period of time, broken into different many fractions of treatment, in order to bring about the best optimal outcome, which is safety and efficacious, at the same time getting the best response in terms of the cancer regression is concerned. So it is something that has been there for many years, but now with this pandemic, these treatments have to be abbreviated, even though it may not be the optimal means. Patients undergoing radiotherapy, of course, they will have to wear masks. They will all have to have temperature checks upon arrival, and in many cases where they are high risk, they will have to have that COVID-19 testing, and even some cases low dose CT scan. The layout for radiotherapy department will be adjusted so that there will be one-way pass, no intermingling of patients who are going for treatment and then are finishing treatment, crisscrossing, and that sort of thing will be less. And so in future, radiotherapy departments will have to be planned in such a way so that patients keep a certain distance from each other. I already mentioned about modifying radiation protection protocols such that in future treatments will be over a shorter period of time. One of the important aspects of radiotherapy is that we use chemotherapy to sensitize the cancers to radiotherapy treatment. So very often radiotherapy is given concurrently with chemotherapy. The effects are good as far as the cancer control is concerned, but of course it also means when you are giving more than 1 or 2 treatments at the same time, there is a higher risk of myelosuppression, immunosuppression, and that itself can carry a risk as far as COVID-19 infection is concerned. So other general principles as far as systemic treatments are concerned: clinical decisions have to be individualized, and it involves what kind of cancers we are treating, whether it's the primary treatment or we are treating a recurrence of earlier cancers, whether we need to modify or interrupt the cancer, the treatment, chemotherapy, the number of cycles and so on, how the patients tolerate treatment. Generally, withholding critical anti-cancer or potentially immunosuppressive treatment is not recommended for those who do not have COVID-19. Modifying chemotherapy regimens to minimize chances of developing complications for those with less immunosuppressive potential, and avoiding chemotherapy protocols which do not have substantial benefit. Okay, so basically it's a matter of choosing the right treatment protocols, and where necessary one may need to revert to using oral drugs. When it comes to novel treatments, which is is something which is quite relatively new in the last 5 to 10 years maybe, especially like immunotherapy. Even though these treatments like immunotherapy and targeted therapy have less acute side effects compared to chemotherapy, these treatments have a higher likelihood of causing immune related side effects, and therefore one must be very careful when they are using this type of treatments. Look for possible signs of cardiotoxicity and pulmonary toxicity when they are using all these novel treatments. Guidelines for this, a lot of these systemic cancer treatments are in development and continuing to develop rapidly, especially now with this pandemic. Groups such as organizations such as NICE, organizations coming out with new guidelines. The other thing is enrolling in clinical trials. Clinical trials should continue to take place because it gives an opportunity for patients to try out new drugs when they are when they already come to that stage when their cancer cannot be controlled by existing drugs. But we have to be careful, be judicious about who to enroll and who most likely to benefit from such clinical trials. There are various other specific recommendations which we could probably go through quite quickly. Patients with solid cancers who we believe that they will benefit to a great deal from adjuvant treatments like chemotherapy, radiotherapy and so on can proceed with such treatments, but again with due considerations to the benefit risk from that. The same applies to advanced disease. In the case of advanced disease, metastatic disease, patients sometimes can go on palliative chemotherapy for a long period of time, which means that from time to time we might have to give them treatment holidays, give a break from treatment and then continue back. As I mentioned, for hematological malignancies where you're using high dose chemotherapy with stem cell transplantation and things like that, you have to be more judicious. Sometimes you have to do some dose reduction, especially if these are patients who need to be monitored regularly, and if we cannot do that, then we have to consider dose reduction and so on. Those patients with late stage disease, again, best risk benefit to be taken into account, and consider who are those who would have most success and benefit. Consider prognosis. If patient would require advanced stage disease, you have to be very careful in deciding who to treat, not to treat. There are many patients who may best be given counseling and told, look, the situation will be such that they may end up in ICU and that sort of thing, and it may be better to just use some oral medication and home support system rather than putting them on chemotherapy. You must also consider that many patients, if they are with advanced cancer and COVID infection, they have a high chance of requiring mechanical ventilation, and they could end up with complications like the cytokine storm and so on. When it comes to supportive care, again, attempt to decrease blood transfusions where possible, anticipating blood products shortage. Can look at setting up home care services for chemotherapy and supportive care. Appropriate work environment is another important aspect to be considered. During chemotherapy sessions, treatment beds and chairs should be placed with reasonable distance apart. Even in radiotherapy department, sterilization of radiotherapy equipment is very important. Regularly disinfect the radiotherapy equipments that is being used for so many patients, and try to eliminate families being around when patients are undergoing treatment, even though they might want to be very much be part of it. We can use technology like smartphones and iPads for such purpose for patients and family support, and disinfection between patient use. More intense surveillance will be required when patients having treatment, especially when they are older patients with multiple comorbidities. Now, when it comes to cancer treatment, one of the questions will be when can they start when they can retreat, once the infection is over. Again, for that we have ASCO guidelines that recommends that COVID positive patients be delayed for a minimum of 14 days from the symptom onset. Patients should be symptom free after their infection for at least 72 hours without using any medications, and then if we feel that it's safe enough to start treatment, then they can start their cancer treatment again. And many cases they need regular SARS-CoV testing, sometimes maybe as 2 tests in the space of 24 hours. Post-treatment surveillance is very important. Once they finish treatment, how often do we see our patients? Obviously, clinic visits need to be postponed, sometimes delayed. Routine surveillance in patients may need to be delayed. In situations where there's logistical problems, we can use technologies like telemedicine for outpatient care. For in certain situations where need to do toxicity evaluation or do some dose adaptation or recommend certain supportive cares, we can even use telephone and web technology. Okay, important is not only taking care of patients, but in part of the post-treatment surveillance is also taking care of the emotional and physical support of healthcare workers who undergo a lot of stress dealing with cancer patients, especially during this time of the pandemic, and it is important to take care of them also. So, protection of health workers is a very important aspect, and there are, again, it depends on centers. I think in Malaysia we are not so much of a problem, and in my hospital we don't have a problem. I think we got plenty of N95 masks and PPEs and all that. I think our staff are well protected. But if I was working in a less, in a more undeveloped oncological setting, then we will be very careful and judicious about how much of the protection equipment that we need to use. Of course, whatever we do, whenever we do cancer treatment and all that, always take into consideration the possibility of infection control. There are a lot of recommendations as to what one would need to use from head to foot, from overwear and underwear. Of course, we are not going to go through all this, but these are some of the recommendations as far as protection for cancer workers are concerned. So, coming towards the end, we are looking at, with this situation, which this kind of a pandemic, maybe it will come to pass, or we may be unfortunate enough to end up in another pandemic in our lifetime. So for that, we need to have strategies. What are the strategies that we can take into consideration? Just I put this off the top of my head. We should revisit optimal standards of cancer care. We should undertake data collection through specific registry and broad testing of patients with cancer care, so we get more data, more information. Study the prevalence and inclusion of patients COVID-19 specific clinical trials, more clinical trials with patients involving cancer and COVID-19. This will set up the basis of new guidelines. Cancer care specialists should be well versed with respect to these new treatment strategies. we should have an integrated concept of care, emphasizing an immunity enhancement. One of the common things between cancer and COVID-19, if you notice, is immunity. Patients with lower immunity are more likely to get these problems. So we have to look at these protocols which are yet being devised, and this will become the new norm of evidence-based medicine. Diagnostic procedures will be based more or less on less invasive procedures. We should be using the newer technologies, use artificial intelligence and new novel technologies for diagnostic purposes, for example, like liquid biopsies and so on. In the future, I believe routine antigen antibody testing for infections like COVID-19 will become commonplace, and there will be guidelines for such. Hospitals and facilities in future will have to be designed to take into account the risk of hospital-based infections. One of the important concepts that people are exploring is the green hospital concept, where hospitals will be designed better proper construction, operation and maintenance, such that healthcare delivery will be undertaken through environmentally friendly practices. More management decisions will move from evidence-based medicine to value-based medicine, from doctor-centric to patient-centric, and we shall revisit how we can implement multidisciplinary management with the involvement of infection specialists and other physicians in managing cancer. Accessibility to patients, that's one of the problems we have seen, because many people in the community cannot get access. So the needs of the community and the mode of delivery of care, rather than on the technical expertise in specific organ systems, will be the focus. And we can do it through home care centers, mobile services, for example, to get infusions of their cancer medicines at home. So there will be more of a role for home-centered supportive and palliative care services. Enrolling general practitioners who have been all the time dealing with primary care, involve them more in the delivery of health care. Of course, when we do all these things, we have to take into consideration the safety issues when we want to deliver such services to patients, and the cancer and the care providers need to be considered. There will be more emphasis on psychosocial aspects of cancer management, and we need to use more of technology like telemedicine and web-based communication. Lastly, for my take-home message is, well, mankind is making tremendous advancements technologically and so on. But along with that, I think we have to learn to live in balance with nature. If we don't do that, then we will need very, very, very quickly probably another world to live in. Thank you.
Thank you so much, Dr. Jayendran, for the updates. To all our viewers out there, should you have any question for Dr. Jayen, please email to the email address as stated below, and Dr. Jayendran will reply your email as soon as possible. And also, do not forget to scan the QR code at the end of this live by using your MMA phone, Doctor Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link in the comment section to confirm your attendance manually before 8 p.m. today. We have another online CME session with our resident general minimal access bariatric and metabolic surgeon, Dr. Chan Kan-wei, on the topic of bariatric and metabolic surgery for obese and type 2 diabetes mellitus on 6th of November at 6 p.m. Let me know if you are interested. We will share the details with you. We have come to the end of our online CME today. Thank you very much for watching and listening to us, and see you next time.